Okay, ready? All right, any questions before we start? All right, last time we were talking about private insurance. So remember what we're doing. So I'm going through the 4 different tax systems in the US. So you have, if you have Medicare or Medicaid, then you live in which country? The Medicare and Medicaid, it's like what? Which other country has that kind of system? Your options are Germany, England, or Canada. And the answers are not Germany or England. Canada, that's right. So it's Canada. So Canada, that's like Medicare and Medicaid. If you are in the VA or on the Indian Affairs system, then is that like Germany or England? England. And then if you have private insurance, then you're like Germany. So private insurance, remember last time I said that you could get insurance sort of 2 ways, either through your group insurance. Group insurance is like if you get it through the university, then you get group insurance. And the idea is that then it's community rated. Community rated means that we all pay the same amount. Or you could get it from an individual exchange. And so, before the Affordable Care Act, what that meant was basically just going to Aetna and trying to buy a policy from Aetna, or going to some other insurance company and trying to buy a policy. So then I said, well, the Affordable Care Act came along, and that it did certain things, right? First thing it says that everyone has to have insurance. And so either you get private insurance through your employers, you get private insurance through an individual exchange, so it creates these individual exchanges, or you have Medicare and Medicaid. So you have to have one of those 4. I forgot to mention I think I mentioned it, but I didn't sort of highlight it enough in terms of the biggest thing that the Affordable Care Act did, which is that it banned the no pre-existing conditions clauses. So what that said is that before the Affordable Care Act is that your glasses?
No, it should be. Sorry.
It's okay. So before the Affordable Care Act came along, is that insurance companies could deny you coverage based on if you had a pre-existing condition. So what that meant is that, like when you got insurance, you filled this big form about your family history, and that your family history that kind of told the insurance company what kind of pre-existing conditions you have. So it could be something like you have right now. For example, you might say, I used to have diabetes, but it could also be something in your family history. Like, let's say your grandmother and your sister and your mom and all died of breast cancer. Then they might say, oh, you've got a real risk of breast cancer. And so they can deny you based on that. So it meant that this no pre-existing, the fact that they would say you couldn't come in with a pre-existing condition based out a lot of people from the insurance markets. And it also meant that the only people who got insurance then were the ones who, because it was going to be really expensive, the only ones who got insurance then are the ones who kind of passed this pre-existing condition clause, who really, really needed insurance. So when the Affordable Care Act came through, it said, well, no longer is that going to be a criteria, as that insurance companies can't not give you insurance based upon if you have pre-existing conditions. And furthermore, they can't charge you more based upon it. So before the Affordable Care Act, if you didn't have insurance to a group insurance, you'd have to go out to Aetna or to Travelers or one of the other places to try and get insurance. So they would ask you what your pre-existing conditions were, and they had a list of pre-existing conditions, and so they could come through and they could deny you based upon pre-existing conditions. So here's a list on the right there, a list of some of the pre-existing conditions. But the list went on. And the list went on. So in other words, there are a lot of things that they could deny you for. And what the Affordable Care Act did is it came through and it said that, well, you know, they can't deny you based upon it. So what insurance companies would do is that they would either deny you, or sometimes what they would do is that they would give you coverage, but then if you ever make a claim, they'd come back and they'd look through your family history. And if they found that you had an aunt that had breast cancer and you didn't say it, then they would deny you care. I mean, they wouldn't pay for it. So what they realized after some time is that rather than denying people coverage, a better way of doing it, better than saves money or saves them money, would be that they just give you coverage, but then if you get sick, then they would start going through all your claims history, going through any type of information they can find to find out whether or not you left something out. And so you might leave something out like, that you had some type of pneumonia when you're 12 years old. And then you get a condition later on, and they come back and they say, oh, you had pneumonia. Therefore, we're not going to give you coverage because you didn't give us all the information on your family history sheet. And so we're going to deny you payment for your breast cancer or whatever it is. That was called rescission. Rescission then is the process by which insurance companies would deny you coverage of a payment after you have made a claim. So Affordable Care Act got rid of all that. Right? It said that no longer can insurance companies go ahead and when they can't deny you, they can't even charge you different rates based upon the pre-existing condition. So now if you go on the Covered California website, it doesn't ask you whether you have diabetes or anything else. It's that everyone is charged basically the same amount. So it got rid of all that. That was the biggest thing. And also, what used to happen is that people would not change jobs because if they change, like if you're working at University of California and I got diabetes, and then I wanted to change jobs, is that maybe that the new place I go to, the insurance company would say, no, we're not going to cover you because you've got a pre-existing condition. So people were being stuck in jobs because they couldn't change, bring their health care with them to the new job. And that got rid of all that. Okay. All right, so let's see. I went through individual exchanges and sort of this. Remember, the state exchange versus individual exchange thing is that individual exchange refers to that everyone's got to buy insurance. If you don't get through Root, don't get through Medicare, don't get through Medicaid, is that you go on this individual exchange. Some of the individual exchanges were run by states. Other individual exchanges were run by the federal government. Talked about tiers, so there's basically 4 tiers in the plans that you get on these exchanges, etc. And I said that one of the big things that Affordable Care did is to expand Medicaid, so that Medicaid now covers a lot more people than it did before. But the Supreme Court came through and said, oh no, you can't force states to take the Medicaid expansion. And so as a result, some states do, some states don't. That list used to be a lot more orange than blue. And what's happened over time is that the number of states that are accepting Medicaid is growing. Anyway, so that's what it looked like after the Affordable Care Act came through, is that you still had some people uninsured, about 9% of people, but most people had insurance through employer-based insurance now, or through Medicare and Medicaid, and then some people got the non-group individual coverage. All right, so this is an estimate about what would have happened if the Affordable Care Act hadn't gone through. So you can see is that here's about 20% insured and about 9% insured. But really the numbers are a little bit starker than that, because come down here and look. This is what the numbers look like of insured people before the Affordable Care Act, so in 2009. So you have 17% of people uninsured. But then there was another probably 13 or 14% that were called underinsured. And underinsured was, remember I told you about my brother who had insurance policy where he had to pay the first $10,000, and then it would only cover 50% of things. I mean, it was a horrible policy to have. So that's what underinsured means. It means that maybe you have a policy, but it's not really going to cover your healthcare needs. So when they talk about being underinsured, that's what they're talking about. They're talking about people who would have those type of plans that are just really not very good plans. So if you combine the uninsured with the underinsured, you ended up around 33% of people in that category. And that's a lot, right? That's a third of the people in the United States who are under the age of 65, meant that they didn't have health insurance. And afterwards, after it comes through, the uninsured rate goes down to about 9%, and it's about there still. And we'll talk about kind of some of the things that happened to try to challenge the Affordable Care Act as it went through, but it still looks kind of like this. Okay, so one thing that occurred is that when the Affordable Care Act first kind of was passed back in 2011, is that it caused the Tea Party to rise up. So a lot of people in conservative states were very, very upset about the fact that the government was going to go into providing, expanding their healthcare offering. And so a lot of people lost their insurance because they, like I did, I had a plan that was too much of what they call the Cadillac plan. And so that went away. So people like my brother, who was, had a plan where, it was a crap plan, but he had a plan, and then afterwards he had to pay more because he was now having his plan to cover, more things now. And so the Affordable Care Act was pretty unpopular among a lot of people. And that kind of continued on until probably about 2020, and despite sort of repeated type of attempts to get rid of it. And what would happen is pretty much every time that they tried to get rid of it, the number of people who liked the Affordable Care Act would go up. And so over time, what's happened is that the approval rates of the Affordable Care Act are just sort of trending to go up, and you don't really hear much about it. As they don't hear Republican politicians saying that they're going to repeal the Affordable Care Act. All right, and the reason is because if you look at some of the things that once you break down the Affordable Care Act into its kind of components, there are some things like that everyone really likes, like this one, prohibits health insurance companies from denying coverage for people with pre-existing conditions. That turned out to be really popular. It also turns out that clause right there, which is really popular, is what makes the Affordable Care Act really, really tough to undo. And we'll talk about that in a second. All right, let's see. So that's private insurance. That's most people in the country have some type of private insurance. The next group is the uninsured. And I said that if you're uninsured, then you're kind of like you're in India or Colombia or other countries whereby there's a whole swath of people who just don't have insurance. And those countries that usually that you want to get healthcare, you essentially pay for it. In some countries, the way it works is that if you don't really have a lot of money, is that you can go to a hospital, but the hospital doesn't feed you or do things like that. It's expected that your family's going to bring you food, and your family will sort of provide the basic care. And what the hospital does is just provide the doctor goes and sees you, etc. But other than that, all the nursing care and things like that's provided by the family. So that's one way that kind of if you're in a system that's where it's a pay-as-you-go system, is that the family sort of takes over a lot of this type of work. In the U.S., we're talking about people under 65 are typically uninsured, and that they're under 65 because if you're over 65, you get Medicare. Most people are working, but they're working with incomes that are too low to afford health insurance, but not low enough to get into Medicaid or Medi-Cal. So Medi-Cal is in California. The cutoff for Medi-Cal is 138% of the federal poverty line, and that means that if you're working a low-income job, you're probably earning too much money to qualify for Medi-Cal, unless you have children. If you have children, then you might not get it. But other than that, most people who are working some type of job, even if it's it's a $18 an hour job, you're probably going to end up making more money than you qualify for Medicare. So it means that you either have insurance through your employer, and lots of employers don't offer insurance, or you have to go on covered California, and then if you're low enough income, you get a subsidy. You still have to pay for it, you get a subsidy. But then if you're higher income, still not making a lot of money, if you're higher income, then you don't get subsidies. And so the people who tend to not get insurance is that you've got a group of people who are homeless or who are between jobs and things like that, who don't necessarily qualify for Medi-Cal or don't get it for whatever reason, or that they make too much money to qualify for Medi-Cal but not enough to be able to afford insurance. So 77% are citizens and 23% are undocumented or non-citizens. Does that mean that people who are citizens are more likely to be uninsured than people who are not citizens? No, because the majority of people in the U.S. are undocumented. So it means you're more likely, you have a higher probability of being uninsured if you're undocumented. But at the same time, it's not just undocumented people who are uninsured. It's not just homeless, it's not just undocumented. The recent immigrants tend to have actually higher rates of health insurance. It's probably because they can come in and they can qualify for, come in and then you get immigration status that you typically qualify for some type of government service, government Medi-Cal or something. But then what happens is that your income rises, then you sort of stop qualifying. In terms of the reason for being uninsured is that you can see is that 25% are not eligible and it's undocumented, but about 73% the most likely is not able to afford it. Signing up is too difficult and confusing. That's the churn. I think I mentioned the other day that there's some Medi-Cal churn. What that means is that it can be really time-consuming to go through to qualify for Medi-Cal. And then if you change jobs or change areas, you have to go through and apply for Medi-Cal in the new county. So Medi-Cal is a county-based type of system. So if you go from Merced County to Madera County, is that you're going to have a new Medi-Cal provider in Madera County. So it means that you've got to stop, telling Merced County, I'm no longer living in Merced County, I'm not going to qualify for Medi-Cal, and then you have to go down to Madera County, I'm here in Madera County, I need to qualify for Medi-Cal. But it takes time for Madera County, to put you on the rolls. For CalViva to put you on the rolls, and so you might be on 6 weeks, and then waiting for your insurance to pass. Well, if you do then, if you're someone who moves around a lot in jobs, means that, and plus it's pretty time-consuming to go through to do it, and you can get kicked off without realizing you're kicked off if you move addresses and your Medi-Cal doesn't have your new address. Even if you're in the same county, you can get kicked out. So there's lots of reasons why it is that Medi-Cal itself doesn't necessarily make it very easy. So barriers to healthcare among the non-elderly. So this is the number of people who are did not see a doctor or health professional. And also no usual social care, etc. All these things, what they are, they're kind of indicators that are used to identify, who's not getting healthcare. So like no usual social care. If you say that's usually a clue that you don't have someone that you can turn to right away. So if you have some type of health problem, you don't have you're not signed up with a GP or with a healthcare provider at that point. Postpone seeking care due to cost. Everything is more likely if you're uninsured. Paying bills, yep, more difficult if you're uninsured. Okay, so if you're uninsured, what do you do? Well, before the Affordable Care, what would happen is that counties would run their own healthcare systems. They would run their own free clinics. So most counties had some type of free clinic system whereby you could go down there, and a lot of them only ran on weekends, but you could go down on the weekend, and then they would then run a clinic. And the clinics were usually full, chock full of people, because there were people who didn't have health insurance who were waiting for the weekend days to go down to see a primary care because they could see the clinic for free. So, but the counties ran this. And then what happened after when the Affordable Care came through is that, that they looked at what was going to happen. They said, well, most people who the clinic is treating are going to qualify for Medi-Cal once the Affordable Care goes through. So therefore, there's no need anymore to have these free clinics. And so when they took about 50% of the funding away from public health departments, so that public health departments didn't really have the money anymore to kind of run these clinics. Some of them hung on, but sometimes they run like TB clinics, they run certain things, so there's still some around there. But for the most part, counties got out of the business of running clinics for people who didn't have health insurance. Because the assumption was that, they're just going to sign up for Medi-Cal. In reality, what happened is that there's still a lot of people who didn't sign up for Medi-Cal, at least. So, what do people do if you don't have health care? So, if you don't have health care and you get sick, where can you go? You can go to the emergency room, right? Because they have to see you through EMTALA. And so, a lot of people just show up in the emergency room. And so, hospitals then start to become the place where people just show up. And so what hospitals started to do then is that they would start to have groups of people who would, when someone showed up without insurance, they would try to get insurance. So you could get insurance through Medi-Cal. So they would have promotorists and other people working in the hospitals they were there primarily just to help you get insurance once you're in there, because the hospital knew as soon as you came in is that they weren't going to get paid unless they could get you on some type of insurance. Or what they would do is that they would try and find you some other type of plan. So the county has a plan for indigent that they're paying Mercy Hospital for, but you have to apply to the county, so they will help you apply to the county for it. So there are ways to do it, but it meant that subject hospitals became the place where people went to. There's also federally qualified health centers like FQHCs. You'll hear this a lot, FQHC. That's a federally qualified health center. That's a healthcare center that gets some special money from the government, from the federal government, and then they're supposed to also provide care. So it should be is that if you go to, the FQHC around here is Golden Valley. So Golden Valley is an FQHC. Livingston Health Center is an FQHC. That's the big one down there in Fresno. It's based in the name. Anyways, there are different FQHCs around. And so the idea with the FQHC is that if you don't have income, you should be able to pay insurance. You should be able to go into the FQHC. The FQHC doesn't provide you care for free, but what they'll do is they'll provide you care on a sliding scale. So, FQHCs in theory are the ones who should be providing that type of primary care. So if somebody comes into Mercy, and what Mercy will do is first try to get them on Medi-Cal. Then the second thing they'll do is they'll call up Golden Valley and they'll say, hey, we have a patient here that we want you to see. And they'll try and get the person to primary care. Because what they're trying to do is basically keep them from coming into the emergency room and get them into going to primary care. Good example of sacred profane. The sacred type of explanation of this is that Mercy is doing this because people need a good source of primary care, they need a stable primary care provider, and so Mercy is helping them do it. The profane is that Mercy loses money if they come into the emergency room, so therefore Mercy would rather that they go with the FQHC. All right, so then hospitals. As I said, most counties run a hospital. So, like in LA, I think it's Martin Luther King is the USC are both the big county hospitals. Even though they're run by, they're not run by the county anymore. They're the county hospitals that the county pays money to. So, if you're in LA and you're homeless and you need health care, is that you're probably going to be putting it up to a USC Medical Center or to Martin Luther King. If you're in Long Beach, it's Memorial, I think is the big one down in Long Beach that people go to. And what that means is that if you show up at a private hospital in Long Beach, is that they're likely to say to you, they'll treat you for emergency stuff, but when it comes to admissions, they're likely to say, ooh, we need to go over to Memorial, because that's the one for which the county pays for people who are without insurance, or just have, you can have insurance, but if you have Medi-Cal, what's it called? It's the Social Security part of Medi-Cal. It's basically disability on Medi-Cal. It's a certain type of insurance that pays even more against the so insurers, providers would prefer to have private patients, not be fair to the patients. So it's something. And Merced used to run, Merced County used to run a hospital, but then they closed it down. And what they do now is they pay Mercy Hospital to run, to keep, and to provide care. Mercy Hospital used to be located down closer to downtown, and then they built a nice big flash place up here, down here off the road. So Mercy Hospital, why did they build a nice flash place down up here in North Merced? Why didn't they build it down in South Merced where where most of the people are going to use Mercy Hospital? Going to be fun. Yeah. Say it again. Because they want the private payers. That's exactly right. So they're looking to think, all these UC people are going to be living in this region. They all have private. So therefore, Mercy doesn't. They don't advertise that we're the county hospital. Come on in, because they're trying to appeal to people with private payers. Nothing against Mercy. They're trying to make it the best experience possible for people. But at the same time, it's also the one that's in their financial best interest. Okay. Impact of COVID. So first off, that's what happens if you're uninsured. Uninsured doesn't mean that you don't necessarily get health care. It just means it's a lot harder to get health care. And that what you primarily miss out on are primary care. So, and we'll see this when we get to an experiment that was done in Oregon, where the state of Oregon randomly selected some people to get their Medicaid and other people didn't get their Medicaid. And we'll see what happens with that. Because it's an experiment on, what happens if you don't get health insurance? And what you see is that, people don't necessarily die in the life, at least not in the short term. But what happens is that they tend to forego care. They tend to not get preventive services. Lots of other things. They tend to be more in financial distress. A lot of other things that occur if you don't have health insurance. Life just becomes a lot harder. Okay, impact of COVID. These numbers were from a couple months ago. I don't know what the death rate is now. I think we're probably pushing somewhere, because the estimates put the death rate at somewhere between 1.4 and 1.6 million people in the U.S. died from COVID. And that long-term COVID rates are somewhere between 10 and 20%. So how do you feel about COVID right now? Do you think COVID, gone, don't have to worry about it? COVID, slight problem? COVID, more of a worry? Or COVID, big problem? Okay. And what do you think about the universities, kind of the way it's dealt with COVID? Do you think the university's done it well? The university's done okay? The university hasn't done a good job. So, do you think, last COVID question, do you think that COVID is going to be, do you think that we're going to end up having significant amounts of COVID in here this semester? Or do you think that we're kind of just, or do you think we're probably not going to, it won't be an issue? Okay, there's about an equal number of thumbs going in each direction. So, okay, so in terms of what happened with COVID is that, rates spiked and then they kind of fell, right? So you know how that goes. So what happened to the healthcare system? Well, the healthcare system, it kind of varied based on where you were. So if you looked at what happened initially, in Iran, initially in Italy, and then in New York City, is that you had the healthcare system almost getting overwhelmed, struggling to kind of keep up with the case, and They were bringing in lockers for storage units to put people who died in. It was pretty bad. Places like here in California, it hit later, and so they had some time to prepare. So if you look at what happens, what most hospitals did is that they worked with the county public health departments, and that they sort of got ready. So they had, they got rid of all the elective surgeries and all the other kind of stuff, and then they went through and then they started to set up for triage centers. Triage centers means that if suddenly you had a huge number of people coming in, they said then you could put them in parking lots and put them where you're going to go. So they did all that. Overall, what happened is that we kind of never hit those levels. I mean, not the levels that did in New York or Italy, where the healthcare system, like in Italy, they were making triage decisions about who's going to get a ventilator or not, knowing is that if you didn't get a ventilator, you would die. So they were making that kind of cut. Well, this person's going to die, this person has a chance to live. And that never really got that point here. It's not that I kind of heard about. But what it did do for hospitals, it meant that hospitals, stopped doing elective surgeries. And it turns out that hospitals make most of their money off of elective surgeries. So it meant that a lot of hospitals actually laid off a bunch of people and kind of went into dire financial straits initially because they kind of lost all that elective care coming in. Same thing with dentists and other kind of allied health professionals, is that they suddenly, anything that wasn't an emergency, you were pretty much shut down. I had to go to the dentist at one point. I forget when it was. It was sometime when COVID was pretty high, and going in there, it was like walking into people with hazmat suits on, coming through and kind of working on you. It was just, it was clearly, it's like they were not set. They could not do large number of people's coming through. It was done just for emergency type of care. All right, so Medicaid growth. Well, what happened with Medicaid is that it did grow. So when they came through and that they said that when COVID hit, is that they passed laws that basically expanded the Medicaid. And also, more importantly, it said that you weren't going to be kicked off Medicaid if you didn't respond to your letters or whatever it was going to be. It kept you on the rolls. So the Medicaid enrollments, went up pretty dramatically. Now you notice is that down here in California, these states down here, like California, Washington, New Mexico, where Medicaid enrollments are already pretty high, is that you didn't have that much growth. Where you had it in these states that had not done the Medicaid expansion, and suddenly took on and suddenly expanded. So then you saw the growth more. In terms of spending, well, spending, there wasn't a huge change in healthcare spending as a result of COVID, ironically. And it's partly because even though, COVID increased the number of people coming into emergency rooms, they had fewer people going into elective surgeries, and also they had strangely less heart attacks, less strokes being reported, a number of different things that you would think, well, why would you have less of that? But it didn't in the initial days. It could have been because people were having minor heart attacks and saying, I'm not going to go to the hospital. And so they just weren't being treated. But that is something that happened. So as a result, you didn't see these dramatic increases in healthcare expenditures. It's not the point that kind of people thought initially it was going to be. How about overall just spending on COVID? I went through and I tried to figure out, because this is what you do, try to figure out how much the U.S. kind of spent on COVID. And so this is, so being the average treatment in the ventilator is about $22,000. The cost, if you're over 96 hours, is about $80,000. About a fifth of all COVID cases needed hospitalizations. About 5% of those cases needed ventilators. So that, kind of doing the number, and you come up with about, $270 billion. So what's the U.S. spend on healthcare? You know what the U.S. spends on healthcare? It's about $3 to $4 billion, or $1 trillion. So, $300 billion is not nothing. At the same time, it's not like it didn't overrun, it didn't cause this financial collapse. Okay, so spending dropped for a number of different things, but spending rose on other things as a result of it. But I think that the overall impact is that you didn't really see, from a healthcare standpoint, you didn't see a lot of providers going out of business, you didn't see a lot of hospitals going out of business, is that the healthcare system actually did okay in COVID. Now, I think that there are other things that didn't do okay, but the healthcare system itself kind of did okay. There was a lot of burnout from staff, and that kind of started to become more of a problem in 2021 when they started to lose a bunch of staff. Public health has lost a lot of people. So a lot of people left public health. And the reason is because a lot of the anger that people were feeling about vaccinations and mask requirements and everything else is that they kind of took out public health people. Like I was talking to one of my former students who works up in Mariposa's public health, and she said that in the initial days of COVID, is that they were all treated like they were the saviors out there. The public health department was, having good press. They loved the public health department, and it's because they didn't have the cases for a long time. They were one of the last counties to really get hit. But then when it did hit, it hit pretty hard, and so that's when they started to come through to say things like, well, businesses, you got to require to have masks, and businesses didn't want to do it. And so what public health can do, and they have the power to do, is basically go in there and say, well, we're shutting down the business. Well, it turns out that businesses don't like it when you threaten to do it. And then once COVID got more political, is that then it got really ugly, to the point where she was saying this, they had just a day at the market where they had a booth outside, and that they were then going through and just giving out information about giving out masks, giving out information, and people started throwing things at them from the parking lot, throwing food, throwing cans, things like this. It got pretty ugly. So a lot of public health people have left public health because they got kind of burned out. Ironically, I should also say they got burned out, but then public health now is in a hiring mode, and so they're looking to hire bunches of people. So a lot of public health departments are in this weird situation where they've lost a bunch of staff, and they just got a bunch of money from the state government to go out and hire a bunch of staff. And so, good time to be in public health. Okay, next question. Why are there health disparities? So I'll give you my kind of little, the way that I, as a health services research sort of sees these health disparities. It's going to be different than if you were in an anthropology class, a sociology class, or a psychology class. What I'm going to focus on is just primarily from a healthcare system standpoint. What is the meaning of health disparities? Now, in one sense, everything that we talk about in this class is going to be about health disparities. Because when we talk about the problems of the healthcare system, we're never going to talk about problems where we say, and poor Bill Gates wasn't able to get this healthcare, or Elon, poor guy, wasn't able to get what he needs. That's not what we're going to talk about. People who don't get healthcare are people who are basically at the vulnerable groups, lower end of the income scale, etc. Those are the people who struggle with healthcare and get quality healthcare. So when we talk about the problems going forward, is that we are always talking about health disparities. But having said that, there are specific things about the healthcare system and health disparities that I think it's good to keep in mind as we go through. So first off, health disparities kind of, it's differences by gender, race, ethnicity, education, income, disability, geographic location, or sexual orientation. So essentially, it's identifying that there's some identifiable groups who are not getting the same type of access to healthcare as other groups. Now, there's a kind of a change in terms that's gone on in the last 10 years. Is that it used to be is that everything was talked about health disparities, and now it's talked more about health equities. So if you look at the federal government, there's the National Institute of Minority and Health Disparities Research. it's called, which is a big funder of research on health disparities. And that's called that because it was set up in the 2000s when the term health disparities was kind of the term that people used. And now it's much more about health equity. So when I talk to public health departments, they make a point that that they're on health equity, and that health equity is one of their prime goals. So what's the difference between health disparities and health equity? Maybe you read it, have you had this discussion in the class about differences between health disparities and health equity? Show me, say yes. We've talked about this at length versus no. We've never made this distinction or some listening to it. Okay. I'll tell you, so the way I kind of see it is that the difference between health disparities and health equities is a matter of responsibility. So if you talk about health disparities, you can say, oh, there are these health disparities, as if somehow, like are there health disparities between older people and younger people? Yes. In general, there are health disparities between older people and younger people. Older people tend to get sicker than younger people in general. So we think about that as a health disparity because we can identify the difference. But I don't think there's much of a sense that you would say, oh, let's take healthcare away from younger people then and give it to older people to reduce the health disparity. Because you would say, well, that's a health disparity that exists because people get older. As they get older, they get sicker. And so yes, we'll try to give them the healthcare that they need. But it's not like we see that somehow there's an incredible injustice that's done because of the difference between younger people and older people. On the other hand, if you say, is there a difference between the care that people get in South Merced versus North Merced, then you think, yes, there's different health disparities between, there's definitely health disparities between people who live in lower income areas versus people who live in higher income areas. Definitely that. And then it's a question about, well, does society have a responsibility for doing something about it? And if you think, well, yes, that's something that society can and should do something about, then it becomes an equity question, a justice question, not a question just about describing the way the world is as if somehow there's just for magical reasons, people in a low income area tend to afford health and people in a high income area. So health equity then is that the way that it kind of changes the language is that it's not just describing the difference, but it's also saying is that it's something that we can do something about. And so you'll hear this a lot when public health department people talk about their priorities, as they'll say, well, one of our main priorities is health equity. And what they're saying is that not only do they recognize disparities, but they also think is that they can and should do something to reduce those types of disparities. Okay, that said, I'll probably use the terms interchangeably because I'm old, so therefore I'm used to saying health disparities. So, but when I say health disparities, just sort of keep in mind that I also do health equity. So I'm using the term of that society does have a responsibility for doing something about it. Okay, so let's talk about sort of what it means to have differences between inequitable healthcare. So you can think about healthcare in terms of having access to care. And access to care can be you have the opportunity to have the same kind of healthcare. It can be that you have the equity, meaning the actual use the healthcare, or you have the same outcomes. Those three things. You either have the opportunity, you use it the same, or you have the same outcomes. So opportunity means that, like, do people in South Merced have the same opportunity to use hospital care as people in North Merced? Or do people in Madera, do low-income people in Madera have the same opportunity for hospital care as high-income people in Madera? No. Why not? They just shut down their community hospital. Although I just saw that they're getting a bunch of money to try to keep it open. But assuming it's shut down, it stays shut down, that means that if you are high income in Madera, you can go down to San Agnes, or you can go down to the community medical center or wherever in Fresno, and you can get your health care. If you're low income in Madera, is that, and you used to rely upon having a community hospital, you don't have it anymore. So that means that that's an unequal opportunity for access. Here in Merced is that, we have a hospital down here in North Merced. There's no big hospital down in South Merced, right? Most of the specialists are up here on Yosemite Avenue or by the hospital. Most doctors tend to have their practices near the hospital, so they're around the sort of area, not South Merced. So you'd say that, well, just on that basis, there's not the same opportunity for access. Now you can turn around and say, well, wait a minute, it's only 5 miles away, 10 miles away, so therefore it's not that much of a difference. But that's a question then that you're now setting in the ballpark, in the game of trying to figure out, or that you're in the realm of trying to figure out, is that a significant difference or not? And for people who don't have a car, rely upon public transportation, etc., significant difference. That's opportunity. Equitable use of healthcare means, do they actually use it as much? And so why is it that people might not use them? Let's say why is it that people may not use that healthcare the same amount? Don't have insurance. That's a big one. Right? So if you don't have health insurance, you're not going to use healthcare the same amount. If you don't go through and have if the doctor doesn't speak your language, you're not going to use it as much. So there's lots of different things that could mean that even if you live right next door to a healthcare provider, you still may not use it. So equitable use means that you are now going to be looking at the idea about, not just are they going through and having the opportunity, but do they actually use it? And then equitable outcomes depend. That means that do you have the same type of health statistics at the end of the day? So why is it that people might have equitable use but not the same health outcomes? Why might two people have the same use but not have the same health outcomes? Yeah.
Depends on what they're being treated for.
Okay, so it could be is that they come in and that one person has cancer and the other person has a toenail that's it, right? So it could be differences in health status. So like if you look at a young person and an old person going into a healthcare to get healthcare, they could both use the healthcare the same amount. Old person could end up with much worse outcomes than the younger person. No matter what happens, they could end up. So it could be just differences in health status. It could be differences in underlying health status. So maybe if you're smoking and drink and do all other sort of things, or if you grew up in a deprived neighborhood, or if you have lots of other things that can sort of lead that we know are associated with bad health, poor health outcomes as you get older. Could have something to do with that. It has nothing to do with the type of health care that you get. It's one possibility. Another possibility is you get worse health care. Is that they're more likely to make mistakes, more likely to give you the wrong treatments. I downloaded an article for you today. I'll give you later on. Basically, it was the LA Times. It showed that they did a study to identify the number of times pharmacies make mistakes in terms of giving you the wrong medication. Turns out I think it was 9,000 last year times that the pharmacy gave someone the wrong prescription that led to some type of bad health outcome. That's a lot, right? So that can happen as well, which is that you just get worse health outcomes. And it so happens that if you live in an area that is a poor area, is that you're going to end up with worse health, worse quality of care than if you live in a very high income. Okay. So I'll give you an example, a quick example, which is just to talk about COVID. All right. So if you think about, there's two different aspects of COVID. One is who got COVID, and then one is what happens after you get COVID, like what your health outcomes are from COVID. So in terms of who's at risk for getting COVID, during the early days, the people who were at risk were basically people working in the central industries. So we saw this. This was suddenly everyone realizes that there are farm workers. These people called farm workers are actually getting our food for us. And it's because farm workers had to keep on working, and meat packers had to keep on working. But they're working conditions where it's difficult to control COVID, right? Tough to social distance, tough to wear masks, things like that. And then you have risk factors for bad outcomes. Risk factors for bad outcomes from COVID, like age, having chronic conditions, and not getting out of the treatment. Okay, so if you think about this, all right, so here's your, let's say that we have this, here's all the risk factors for getting COVID. Then once you get COVID, you can have a bad outcome or a good outcome. So risk factors where you work, shopping, so can you get food delivered or not, wearing masks, and social distancing. Well, if you then go through and sort of say, all right, so let's see, what are the things that made it worse for people in terms of making them more likely they're going to get COVID? So what is their working conditions? So at the university, I was in a low risk working condition because they came through and they said, okay, do everything remotely. So therefore, I didn't have to go around people for a year and a half. So that, on the other hand, people who are working in the stores, they have to go in every day. So it meant that that right away your working condition is going to determine what your risk is, and that people of higher income tend to have better, more of a chance to do remote work than people of lower income. So that means that that's going to lead to some type of differences in terms of some socioeconomic differences. It's going to lead to some determinants of health whereby certain groups are going to be more likely to get COVID. Businesses taking actions to limit spread. So, more likely in higher income businesses tend to be more likely to be able to limit spread in the low income. And then the third is that the public health system that kind of existed. In the public health system then, you had public health systems that were very well funded and did a good job, and you had public health systems that quickly became overrun. So a former student used to run the public health department in Santa Barbara. And I talked to her when this first started and asked how things was going, and she said, fine. They had 20 people that they hired right off the bat to be contact tracers. They had the hospital system all set up. They had, so basically they had, from the very start, they had things relatively under control. I then talked to someone who I worked with down in Madera County, and it was just, he said, well, we have no idea how many people have COVID. We have no idea. There's not really testing going on. We're starting to do testing, but not as a way of doing contact tracing, because that's just, we can't do that. That's gone now. All we're doing is just trying to figure out what the rate of infection is. That's the only thing we're trying to do. So there you have public health system one, Santa Barbara, one of the wealthiest counties in the state, that had things fairly well under control. Then you have Madera, not very well funded, that didn't have things under control. So if you put all those things together, then you can sort of see is that, well, that's going to cause health disparities in terms of who gets COVID. That people who live in working places that you have to go to have business, are in a business where they're not going to do a lot to limit the spread, and have public health systems that are not very good, are going to have higher rates of COVID than people who live in other areas. So is that an unavoidable health disparity, or is that a health inequity? Health inequity? No health inequity. Unavoidable. Okay. Unavoidable, someplace in between. Well, you can ask yourself, could something have been done, right? What about the workplace stuff? Could something been done for meat packing plants? Sure. Could have, right? For farm workers, could they have used different types of transportation to limit the spread? Yeah, could have. Why didn't they? It cost money to do it, right? Could the public health system have been funded to the level whereby they were essentially had more ability to do all these things? Yeah, could have. So that's why when you look at this, you start thinking, well, yes, there's definitely a health inequity, a health disparity, but it also probably fit into the health inequity thing, in that there's something could have been done about it, but just for lots of different reasons wasn't done about it. All right. Then if you look at who then got sick and who got good, what determined whether there was health inequalities and inequities about outcomes from COVID, which you get it. Well, one of the big determinations about whether or not you recovered was whether or not you got good treatment. So Trump gets it. Trump goes off to Walter Reed Hospital and recovers. Other people, if you don't have Walter Reed Hospital there and you don't have access to ventilators, then you didn't recover. So, you can sort of go through and sort of do the same type of logic here. To kind of come out and say, well, a lot of the problems that exist in terms of outcomes were dealt with that. They were things that there was nothing intrinsic about the individuals who got it. It was just the way that the healthcare system is set up. And I think that that's the conclusion about the healthcare system that comes from COVID, is that all of these problems that we're going to talk about in this class, all of these things, the problems with all the different systems, et cetera, they were things that we were talking about 10 years ago, 15 years ago, and that always knew that there were problems. But what COVID did is that COVID just highlighted them. COVID came through, and then all these different things are problems all the way through. COVID just kind of went through it showed that the major problems of what can happen if you don't have a well-functioning health system. And you look at other countries have better health systems, so they didn't have the same problems that we have. All right, let's see. Okay. So one of the last things to point out is just in terms of, you notice that when we start talking about different types of ways of that socioeconomic status is associated with health, is that, well, there's different ranges of socioeconomic status, right? Education, income, there's social class, there's the community that you live in. So there's lots of different measures of socioeconomic status. And they kind of represent different type of things. So when we think about education as being a measure of socioeconomic status, there's this kind of assumptions that, well, people don't have the same level of health literacy, there's something about knowledge that's making it that people are worse off. When we think about income, then it's a question about why would income have that big of an impact? Well, one is that income is a proxy for lots of different things. It's a proxy for stress. It's a proxy for just taking more in your life. One thing that I've found as I've gotten older and I've gotten a higher salary is that what income does, it just makes things easier. Right? You can go into a store and instead of having to worry about what type of butter that you want. You want butter, and you just get butter. It looks like a nice butter, you can buy a nice butter, and you don't have to go through and think a lot about it. Whereas, when I was in the days when I didn't have much money, when I had a couple of children, it's like what kind of butter you purchase was a big deal. And so, those type of questions then are things that income makes it so that you just have, it's not like all your problems go away as you get rich. Ask Elon Musk. But what happens is that it makes things easier. It also leads to things like food security. It also leads to better access to healthcare, etc. So if you look at the areas that have higher adjustment, this is the income basic levels of places, is that you can see the red is essentially the population level, and then the blue over here is basically where you have high incomes. So we are in an area here that has lots of people, because along that line there is the 99, and that it also has low income. So urban coastal areas tend to have, in California, tend to have higher income, and they tend to have higher rates of private insurance, and they also then tend to have more doctors. So why do places that have higher incomes have more doctors? Well, it's because, people who are privately insured are going to, doctors who who see people who are private insured get paid more than patients who are on Medi-Cal or Medicare. So this is, right now, 57% of people privately get insurance, privately insured in California, 60% on Medicare, 35% on Medi-Cal, about 9% have no insurance. In terms of the reimbursement rate, private is the highest, then comes Medicare, then Medi-Cal, and of course uninsured, where people have to pay out of pocket, is the lowest. So I'll show you some numbers here. So this is, private payer rates are higher than Medi-Cal rates for physician services. So this is the difference now, how much more private insurance pays than Medicare pays. This shows that Medicare, shows the ratio of Medicare and Medicaid spending. So basically Medicare pays a lot more than Medicaid or Medi-Cal. So like in California, basically Medi-Cal pays about 73% of what Medicare pays. And then it varies. And notice that some places are higher, right? Medicare pays, Medicaid pays more than Medicare, but most places Medicaid pays less. And so this is what it means. It means that there's a service that a private service that if you're privately paying, the doctor would get $100 for, or the hospital would get $100 for. For Medicare, it's only going to pay $50. For Medi-Cal, it's only going to pay $39. And then for no insurance, it's only going to pay $5. And for a physician, it's $100 to $70 to $47 to $21. So if you're a doctor and you on one hand you want to help patients, on the other hand you do like money, then where are you going to locate? You're going to locate places with lots of private pay patients, right? Where aren't you going to locate? Places where there's lots of unemployed and lots of Medi-Cal, right? Where are we right now? A lot of unemployed, a lot of uninsured, a lot of Medi-Cal in this region. In San Rafael, Marin County, a lot of private patients. So it means that that fact alone means that explains why it is that there are more doctors in the Bay Area than there are in these regions, because the reimbursement rates are different. So therefore, not only that, but also, no offense against any doctors, but if you talk to doctors, they'll say that the doctors come here. I mean, some of them are great doctors. Some of them, though, not great doctors, and they're more likely to end up in a place like this than they are in a place like Marin County or Kaiser. So it means that not only do you get, kind of less doctors here, but the doctors you get tend to be not as well trained or whatever measures of quality you want to use to go through it. So the way that this comes out is in what's called the medical shortage area or medically uninsured area. And so this is like a designation that is really important to understand. So what this shows is basically, this is the hospitals, California, OSHPD, the state hospital system, or not the state hospital system, it's the government agency that oversees hospitals in California. What they do is that they break things up by frontier, where there are very few doctors and hospitals, rural, and then urban. So urban then has a certain population, population based, and then these rural areas are kind of like, we're probably in a rural area. We're saying it's a bit weird because the population is 280,000 per county, which is actually above what usually, 250 is usually the rate that below 250 they start calling it a rural county. But yet so many different places in the county here are rural that we're really a rural county. And then frontier, like Death Valley is the frontier area, things like that. Well, this is the medically underserved areas here. There's going to be all of these areas basically in green here. In dark green are areas where there are fewer doctors than areas where in the white or in such. So essentially you can see is that all the San Joaquin Valley here is pretty much a medically underserved area. What that means is that we have fewer doctors than places like Marin County does. A lot fewer doctors than places like Marin County does. So it means that when we go through and that we start to talk about healthcare access here and health disparities and everything else, one of the main things point to is to say, oh, well, one of our problems is that we just have fewer doctors everywhere. So if it's tougher to get a doctor here, and the reason why it's tough to get a doctor here is, one, people might like to live in the Bay Area, but the other one is that we have 50% Medi-Cal people on Medi-Cal. We have 25% people on Medicare. So that means that 75%, and we have probably 10% of people, 15% are unemployed or uninsured. So that means that right there, you have 80%, 90% of people who are going to be paying doctors less than they get paid if they're in the area without high private insurance. Okay. All right, let's see, what else? Yeah, well, why don't we stop there? Any questions? Okay, well, we'll start there next time. I can see that you've heard